This is very exciting. We're excited to start this stroke education series. Inshallah, the lecture is going to be in English. If you feel like I'm speaking too fast, let me know. If you have any question, let the moderator know, and he will let me know, and I will try to answer the questions and clarify if you have any questions. Okay, so we're gonna start with the first lecture, neurological exam in stroke patients. Now, this is a big topic. An hour is not, we'll try to summarize and get to the, tips and points in neurological exam. Neurological exam is so big and vast. Now, for the purpose of the lecture, we are talking about examining a stroke patient after the acute phase, because we're going to talk about this later. So first, let's start with some definitions. So what is stroke? So stroke is
اسف المقاطعه دكتور، اسف المقاطعه. انا دكتور عبد الرحمن من مكتب تركيا، بس نحن يعني العاده بيتم العرض الماده باللغه الانجليزيه بس الالقاء باللغه العربيه، يعني اذروايز ما راح داخل سوريا ما راح يفهموا المطلوب، يعني ما راح يتم التفاعل.
نحن حكينا بهالموضوع من قبل وكانت المحاضرات هيك، ولكن قررنا بهالمحاضرات ان يكون كله بالانجليزي لاكثر من سبب. ما بعرف اذا الدكتور ماهر هو بتحب
يا الدكتور احمد مطلق كمان معنا. ان شاء الله نحن حنباشر باللغه العربيه باللغه الانجليزيه. نترك اخر just 10-15 minutes للنقاش، واي سؤال نحن بنقدر نجاوبه باللغه العربيه والامور، بس انه نحن اذا بدنا نوسع النطاق للباكستان لمقديشو ان شاء الله وللويست بانك باذن الله، مضطرين انه لازم الالتزام باللغه الانجليزيه ان شاء الله. تفضل.
Some definition. Stroke. What is stroke? Stroke, neurological deficit attributed to an acute focal injury of the central nervous system by a vascular cause, including either it could be an infarction, it could be a bleed, hemorrhage, or subarachnoid hemorrhage. So an infarction, what is an infarction? When you say infarction, is brain, spinal cord, or retinal death attributable to ischemia of the cells of these organs. Ischemic stroke, which we all, like when we say stroke, we all referring to ischemic stroke most of the time. So ischemic stroke specifically is a neurological dysfunction caused by focal cerebral, spinal, or retinal infarction, which is cell death. So neurological exam is something for the non-neurologist is considered to be something scary or intimidating and time-consuming, boring, a lot of details. So that's for the non-neurologist. And whenever they find a neurological patient, they just want to consult neurology. And every neurologist has his own version of neurological exam. Nobody is like more correct than the other. I might like to do it this way. Other neurologists might like to do it the other way. You can make your own version. There's nothing wrong with that. But the purpose of the exam is a continuation. After we take a history and then we do exam, we always think about where to localize the lesion. And to be able to also to, try to know the cause, localization and cause by history and then by exam. The most important part of the neurological exam is observation. You can know a lot from just observing the patient when you are taking a history. So that's the first part of the neurological exam. It's very, very important. And we'll talk about it a little bit more. So you'll see the patient, you see how his demeanor is, how his face is, how facial expressions, how he moves, how he thinks, how he speaks. All this observations gives you a lot, and that's part of the neurological exam actually. So sometimes even you can localize based on your observation, where could the lesion be, and that can direct you when you are doing a neurological exam. So do you have to do everything in neurological exam? If you are going to do everything, that's gonna be a waste of time. So sometimes you have to have a routine of things that you do all the time, and then you can expand on if you feel like I need to do more on the sensory, I need to do more on the motor. It depends on the patient and the history. So you cannot do everything all the time, but that's my preference is I have a way to do my exam, and then I expand if I need to on the exam. So I have a sequence that I do, and this is the same way that I write it down in my note too. So I have the same sequence in my notes. If you look at my notes, they're all the same sequence, but it varies from patient to patient. But it's good to have like the same sequence. Even when you examine the patient, do the same thing every time. You're not gonna miss anything. It's gonna be more organized, and it'll help you with localization too. So for the acute settings, like when patients are in the ER, they are acute patients coming in the ER within the window for tenecteplase or alteplase. The exam for that patient might be a little bit different for the paramedics, which are the ambulance people, or for the ER physician, or for even the neurologist, or for the telestroke neurologist. That this is more common now, to have a telemedicine neurologist who examine the patient remotely. So this is called NIH stroke scale. This is going to be a different lecture. Dr. Saqur Maher Saqur is going to speak about it in next lecture, inshallah. So we're not talking about this setup in the acute setup. We're talking about a stroke patient exam after that acute setup, because the purpose is different between an NIH stroke scale and the neurological exam after admission. Okay, so neurological diagnosis start with the history. The tools that we have, the history is the most important tool that we have. If you know the history, things are going to be much easier. If you don't have a good history, no matter what tests you do, sometimes you're not going to be able to get the right diagnosis. So a careful history is very important. Now, sometimes patients are confused, sometimes patients are demented, you cannot get a history from the patient. It's good to reach out to the family, to the witnesses of this event, and we have many examples of how much this saves you time and effort and studies if you have a good history from the patient, family, or friend, or whoever was with the patient at the time or before they came into the hospital. You need to know the chief complaint. Why exactly the patient? What brought him into the hospital? Because that's also very important, and that will lead you to the right diagnosis. You need to listen to the patient. A lot of times we're in a hurry, we're trying to rush things, but you need to listen. You need to give the patient few minutes to speak about why he is in the hospital, why what's his complaints. I know that some patients will talk a lot. You can stop them and redirect them. But in general, you need to give the first few minutes for the patient, just ask him general question. Why did you come into the hospital? Let him explain it to you. You'll get a lot from the patient just from listening to the patient in the first few minutes. And then at the end, if it's a little complicated, you can summarize the history to the patient and tell him, okay, so this happened and this and this and this and this. Did I miss anything? So when you summarize it to the patient, this will help you and help the patients just to be clear. Okay, so let's dive into the neurological exam. So the first thing, it's probably not, you're not going to see it, but it's the general exam. The general exam, as we said, it's observation. Observation of the patient is extremely important. First thing you do when you go into the patient, sometimes they're covered. They have like more than one cover. Uncover the patient, you're going to see a lot. When you uncover the patient, you're going to see tremors, you're going to see other movements, you're going to see, like, for example, rash. Of course, you're not going to cover the whole body. What I'm talking about is just take the covers of the patient. Of course, you're going to keep the gown on unless you need to look at certain areas of the body. But if you uncover the patient, you're going to see a lot. You're going to see how they interact. So that's very important. So observation is the first thing you do while you are taking the history from the patient. Mental status exam. And this is how I do it. So general mental status exam, cranial nerves, motor exam, sensory exam, reflexes, coordination, and gait. This is how also I organize my notes. So every note has all these elements in it, but that's my personal preference. Everybody's different, as I said. So mental status exam, first level of consciousness. You see the patient, you tell, is he awake? Is he alert? What level of consciousness? Is he sleepy? Is he stuporous? Is he comatose? So that's something that's first level. You need to know level of consciousness, and you describe it. And then you speak with the patient and ask them about orientation. Are they oriented to themselves? Can they tell their name? Are they oriented to the time? Are they oriented to the place where they are at? And then by taking you ask the patient, sometimes the family will take over, stop the family. You ask the patient, why did you come here? See, is the patient able to give you history? Is the patient coherent enough and have enough alertness to give you history or not? That's very important. And then while you're talking to the patient, you observe their speech. So you observe their spontaneous speech, and then you can ask them specific questions to test for their speech. For example, in patients who are dysarthric, they're not going to have any problem with producing the words or understanding what you're saying, but it's more problem with articulation, problem with the mouth and the tongue. They're weak. The words do not come out with the right articulation as I'm speaking now normally. If they have like dysarthria, they have mild dysarthria, things are going to be, my mouth. So it's going to be this, but you're going to understand here, they understand, they have good comprehension. In patients with aphasia, it's different. And there are different types of aphasia. We're not going to go into details of these, but you have to examine fluency. Fluency is when you're talking to the patient, to how fluent is their speech, how easy can they come out with words and express themselves. And then you can check for naming. You ask them like to name two simple objects like a pen or a watch or a tie, and just ask them to name the objects. You ask them to repeat a sentence, a simple sentence. For example, here we ask like, today is a sunny day, or no ifs, ands, or buts. Of course, you're not going to ask these to patients in Syria. You're going to choose a simple sentence in Arabic and ask the patient to, repeat it. And then when you are asking him to do, you'll find out if they are comprehending what are you saying and they're following your commands. So that's comprehension. So are they receiving these orders and applying it? So you get a sense of, do they have receptive aphasia other than expressive? Expressive is when they have difficulty getting the words out and expressing themselves, but receptive is understanding orders, understanding speech. Also, if you want to expand that more, if you have the time, you can ask the patient to read and write. But again, sometimes we have limited time, so do your best. But if you feel like, there are some stroke syndromes, like for example, some patients can write, can read but cannot write, for example, right? So if you want to expand your exam, you can do that. Cognition. Okay, so we talked about orientation. When you're talking to the patient, you can test their memory by asking them 3 words to remember later, but you can tell sometimes if they're remembering the events, if they're remembering certain events or not, and you can get a sense of their memory. And then you can expand your exam more if you feel like, he's having this problem. Let me check, is he able to do calculation? Does he know his right side from his left side? Can he do serial sevens? Can he spell a word backwards? So you can expand that. I'm not saying you have to do it on every single patient. It depends. When you see the patient, like almost everything is fine, he looks normal, he's speaking normal, you don't have to expand. You expand these on patients where you are suspecting that you're going to find more on the exam. And then mood. Mood is how the patient feels. Does he, you can ask the patient, do you feel anxious? Do you feel depressed? Do you feel happy? Do you feel whatever? So this is the mood of the patient or how he feels. And then the affect is how the patient looks. The patient looks depressed. The patient looks anxious. The patient looks in pain. That's the affect of the patient, how he looks to you. The patient has facial masking. He has Parkinsonian. He's Parkinsonian. He has facial masking. This is the affect of the patient. And then thought contents. Are the patient speaking with a full sense, or they are paranoid, or accusing nurses of they're going to kill him, or he's psychotic, or he has hallucination and see things around him. So these are the thought contents that you can get from the patient as you are speaking to the patient. So this is the mental status exam. We move forward to cranial nerves. Cranial nerves, we have 12 cranial nerves. We don't examine all the cranial nerves every time, just to be honest. But you can, again, expand as you are doing the exam, but write down what you did. Don't write down like just all cranial nerves are fine. Try to write down what you did. That will help you and help other people who are reading your notes to benefit from your exam, because they are trying to compare their notes to your notes, or their findings to your findings on the exam if somebody else come and took over the patient. So cranial nerve 1 is olfactory nerve. If you want to examine olfactory nerve, you can have like a little bit of coffee, for example, in a small bottle in your bag. And you can ask the patient while their eyes are closed to smell and tell what do they smell. That's the simplest way to examine olfactory nerve, for example. And that's just an example. You can do it in other ways too. Cranial nerve 2, which is the optic nerve. So optic nerve, we have more than one modality that we need to test. The most important, and a lot of times people do not do it, ER physicians, primary care, even some neurologists, is the visual fields. Visual fields is very important, and sometimes patients, actually a lot of times, patients who have visual field cut or homonymous hemianopsia, they are not aware of it. You find it on the exam, but the patient is not sometimes aware of it, and he's not complaining about it. So that's very important to examine it. And now, how to examine visual fields? I'm going to show you my way, and I feel like it's a practical way. We're going to ask Joyce to have a seat here. So some people, it's called confrontation, exam by confrontation. So what some people do is ask the patient to count fingers. That's my personal preference. I don't like it this way, because even myself, sometimes I cannot count these if I have 2 or 3 here. It's impossible. So the better way to do it is to wiggle your fingers and move your fingers and ask the patient which side is wiggling, which side my finger moved. For example, I ask him where Joyce, and you can examine quarters, so upper and lower quadrants. Sorry, not quarters, quadrants. So upper and lower quadrants. So point to the side that you see moving.
Okay. Dr. Ziad, are you showing how you are doing it?
Yes.
Because we cannot see we can see just the screen.
Oh, you're
Am
not
I
seeing the video?
Let me just see. Oh yeah. Now we can see. We can see. I think it's. You have to look at the yeah. Very good. Everyone
Yeah,
sees
it's my video.
Wonderful.
Okay. So you are sitting or standing in front of the patient, and you have to see what you. So if what you see is what the patient should see. So you ask the patient which side is of my fingers is wiggling. They can point at it, or they can tell you. It's better to point at it, or if they cannot, or they're a little confused, sometimes it's easier to say. So which side is wiggling? You can talk.
Both sides.
Okay. How about now?
My left, your right.
Okay.
My right, your left.
And then you can do the lower quadrants.
Fold. Right.
Okay.
Your
So
right,
this
your
is.
left.
Thank you. So this is how I prefer to examine visual fields. Again, everybody has his own way. Some people like to examine every eye separately. So they ask the patient to cover one eye and they examine the visual field in one eye and then the other. Visual acuity, I don't examine it on every patient unless they have visual problems, and I use the visual card. Or the vision card. I'm sure you guys know about this card and a lot of people have it. So this is the card. You ask the patient to hold it about 14 inches, which is almost like this far. And you ask them to read the numbers and you see where they get, and you have the scoring on the side here. Okay. And then on the same card is you have the sizes of the pupils here at the bottom. If you want to see what's the size of his pupil, so you can compare it to these kind of spots and everywhere. Okay. So that's visual acuity. And then fundoscopic exam. I routinely do fundoscopic exam on all my patients. And the reason is I don't like to lose the skill. Now, does it help me all the time? No, but in certain patients, it does help me a lot. You don't have to do it on every patient. Again, this is an expansion of the exam. But if you get used to it, it's going to be so easy. The more you do, neurological exam, the more you do in your routine, and you feel more comfortable, and the more you find out on next patient. So that's just a personal preference. I know that in stroke patients, is it going to benefit you in a stroke patient specifically? Not that much, but in other patients, it depends on the case. Okay, now we move to the next set of cranial nerves, which are third cranial nerve, the oculomotor nerve, and fourth cranial nerve, and sixth cranial nerve. Okay. So why these are connected together, trochlear nerve, abducens nerve, and oculomotor nerve? Because they control the extraocular muscles of the eyes. And that's how we move our eyes together, and how, our brain and eyes work together for us to see with a conjugate aligned gaze with both eyes. So we have to remind you that the pupillary light response, which is light reflex, also a lot of time people do not do it. Make it a habit. It's easy with a flashlight. Don't examine it in a bright room because you might miss a reaction. Especially, it's better to dim the light in the room so you can get a better reaction of the pupils. This table here explains some of the abnormalities that you guys know about. We're not going to go over. The time doesn't allow to go over them, but I'll send you the slides. You can look at them. But for example, a patient with drooping of the eye and dilated pupil on the same eye, you think it's probably an oculomotor, a third cranial nerve. If it's a smaller pupil, you think about Horner syndrome. So pupillary eye reflex It's very important. You have to sometimes ask the patient, did they have surgery on their eye? Because sometimes if they have a cataract surgery, they might not have a reaction of that eye. Did they have injury to the eye? Look at the pupil. Is it round and crisp edges, or it has an irregular edge? So that will tell you, give you an idea. If the patient is, for example, have decreased level of consciousness, you need to examine the eyes, and especially the pupils. Let's say the patient has a big stroke and they have edema and they are herniating. It's very important to look at the pupils to save the patient's life if you find a dilated pupil, for example, on one side. That could be a sign of increased intracranial pressure. So make it as a habit to examine pupillary reflex. Now, there is also another implications for other diseases like the afferent pupillary defect that we see in optic neuritis, for example, but we're not going to expand on this during this talk here. Okay, next is the ocular movements. So ocular movements are very important and sometimes difficult, and they need like lectures to speak about everything. But we're going to talk about two important eye movements: the pursuit and the saccade. What is a pursuit? When we follow an object, when I have my finger here and I said to the patient, follow my finger with your eyes. So I'm looking to the left and following the same object to the right side. This slow movement, that's called pursuit. That's called pursuit. So I'm following an object. So my eyes are trying to fixate on this object and try to put it on the retina so it'll be fixed on the retina. Okay, this has a system that goes from the ipsilateral parietal occipital and then goes to the brainstem to the parapontine reticular formation, then to the sixth cranial nerve on the same sixth cranial nerve nucleus on the same side. Then from the sixth nerve, it goes to the ipsilateral, the same side, lateral rectus muscle that moves the eye out, but also to have the same conjugate gaze in the other eye, it has to go to the medial rectus muscle on the other eye. So the eyes both move together. That's why we move the eyes conjugate gaze. We call it conjugate gaze. Aligned eyes. The eyes are aligned, so they're conjugate. So that you have this pursuit. This is for slow eye movement. Now the saccades is the fast eye movements. So I ask the patient, look at my finger on the left, look at the right. So they're making quick movements. They're not following an object, but they're trying to fixate an object in a very fast movement of the eyes from one side to the other. It's called saccade. The saccadic eye movement are controlled by the frontal visual field. There's an area in the frontal lobe that controls the contralateral eye movement and goes from the frontal lobe and it crosses to the other side and goes the same route from the parapontine to the sixth cranial nerve, and then you have the medial longitudinal fasciculus that goes from the sixth nerve nucleus to the other side to the third cranial nerve and goes to the medial rectus muscle, so we can see. So the center is different, or the control is in frontal lobe eye field center, whereas the pursuit, the center is in the occipital parietal cortex. So those are two very important eye movements. Now, the vestibular ocular reflex also, so we have another system which is also involved with the ears, with the balance center in the and the vestibule in the ear, which can talk to the nucleus in the brainstem, and it's separate from the supranuclear control of the frontal lobe and the parietal occipital lobe. So when you have a patient who is comatose and you do the doll's eye, where you move the head to one side, the eyes should stay midline or move to the other side. That's a normal response. So you know that the patient has normal brainstem. Whereas if it's abnormal, that means there's a damage in the brainstem. But that's also another, needs just a lecture by itself. Okay. Then you examine the extraocular muscles. The extraocular muscles, as we know, moves the eyes horizontally and move the eyes up and down. Now, if you look at this picture here, to move the eyes horizontally, you need the lateral rectus, which moves the eyes outwards, and the medial rectus muscle, which moves the eye inward, okay? Now, how do we examine the extraocular muscles? There are two ways. Either you do an H shape, which is you go horizontal first to examine the horizontal, and then on the sides, you go up and down. And on the lateral side, you're examining actually the superior rectus muscle and the inferior rectus muscle. When you go in, so the eye that is outside is you're examining the superior rectus and inferior rectus. On the other eye, which is inside, you're examining the inferior oblique muscle and the superior oblique muscles. Those are muscles that turn the eye and move the eye up and down in the medial when the eye is medially, and rotate the eye too. So there's this way of doing the H like this, and then up and down on the side, and then go all the way up and down. Okay, so this is one way. Or you can do the box, which is you go horizontal first, and then you go into like a rectangle all the way down to the four corners to examine different and all the eye movements, and then explain, do you find a weakness on the eye muscles? Okay. You can look at this picture later. This is what we talked about, the visual, that's the horizontal conjugate gaze that goes from the frontal lobe, as we spoke, to the brainstem. And that's just an explanation, but it's out of the scope now to go in details into more. Now, that we have to look for is nystagmus. And nystagmus also is a significant topic here, because sometimes patients with stroke, they come with nystagmus. So we have to differentiate, is this nystagmus, the patient comes in with vertigo, nausea, vomiting, unsteady gait. Is this a central problem or a peripheral problem from the inner ear? So we look at if the patient has nystagmus, we have to look at the nystagmus itself. Which side, we're looking at the fast beat. So you know the nystagmus is like, I'll show you a couple of examples now. But you have the fast and the slow beat and the fast beat. So we're looking at this fast beat. Where is it going to? Is it all the time going unidirectional, one side only? Or when they change, it goes to the other side, so bidirectional. So when you have somebody who comes in with unidirectional nystagmus, meaning on always the fast phase of the nystagmus is to one side, most of the time it's peripheral. When you have change in the direction of the nystagmus, or the nystagmus is significant and severe in all directions, no matter where they look, you find large nystagmus. In peripheral, when you look to the side of the lesion, it will be more. When you look away, you might see it, but it's going to be a little less. But in central, like cerebellar or brainstem infarct, for example, the nystagmus, even if it doesn't change direction, it's going to be significant in whatever the patient move their eyes. Okay. So another thing that we have to look for in patients, especially they come with acute stroke, is gaze preference. Some patients you go in and their eyes are deviated to one side. So, and usually to the side of the lesion, because as we said, the conjugate eye movements are controlled by the frontal eye field. So when that is damaged, the eyes are not gonna be moving this way, because this eye, which pushes the eyes to the other side, you have balance between both sides. So when this eye is damaged, the eyes are gonna go to the damaged side because the other side is taken over. And that's what happened in patients with large strokes. Usually it's called gaze preference. So the patient might not be able to move past midline. So they move the eyes, but not past midline. And they have a lot of time with that. They have, if they have parietal also damage, they have neglect to the other side too. And we have to look at if the patient have ptosis, drooping of one eye or both eyes. But what controls the eyelid is the levator palpebral muscle. That's one muscle that controls, that's the major one, and it's supplied by the cranial nerve 3. That's why in cranial nerve palsy, you see drooping of the eye, and it's more prominent. Another eye is called superior tarsal muscle, which is supplied by the sympathetic nerve system that goes from the hypothalamus all the way down to the neck and goes around the carotid artery and go up to the eye, go to the sympathetic and supply and help with the dilating the eye. So for example, if you guys can answer, it'll be perfect. Like this patient, can somebody tell me what's wrong with this patient, or I should just explain? Can you tell me which cranial nerve is affected or what system is affected? Anybody can tell?
Third nerve.
Okay, why is that?
So this right eye and the problem.
So right eye is what? What's the problem with the right eye?
Ptosis and dilated pupil.
And what? Sorry. So ptosis is correct. And if you see the eye is going outwards, right? So that's
deviation to right.
Out and down, right?
Right.
So that means the medial rectus muscle is weak. And also what other sign also you can see? One more sign. Look at the pupil. It's dilated. Right, so dilated pupil. So this is a complete third cranial nerve palsy, right? When it's spared the pupil, because sometimes you can have a partial, which is sparing the pupil. Not all the time you will find the pupillary involvement in third cranial nerve, but this is a third cranial nerve palsy, okay? How about this patient? Oh, how about this one? What's wrong with this picture? Anybody? Where's the abnormality? Which eye?
Left eye ptosis.
Okay, what else? How about the pupils?
Pupil small.
And on which eye?
Right.
So which one is the abnormal pupil? Right or left?
Normal.
The abnormal.
Abnormal left pupil.
Correct. So the left eye is you have ptosis on the left eye and you have small pupil on the left eye. What do you call this? This is not third cranial nerve, right? Horner. Yes, you're correct. That's a Horner syndrome. Yes, that's a Horner syndrome. So the ptosis is not as bad. The pupil is smaller on the left side, and there's no eye movement abnormality. The eyes are conjugate. You see, they're aligned, not like the third cranial nerve, right? So the best way to get more of the difference between the pupils is you turn off the lights and you see more, the right eye will dilate more and the left eye, so you see a bigger difference when you check the pupils in dark. Okay, So what's acceptable difference if somebody has an unequal pupils? What's the acceptable difference between both eyes? Anybody can know? Anybody knows? So if the right eye is 4 millimeter, the left eye is 2 millimeter, is that acceptable or not? Is it within normal limits? No. The acceptable difference between both pupils 1 millimeter only. Anything more than 1 millimeter difference is abnormal. Okay? All right. We move on to the next cranial nerve, nerve 5, trigeminal nerve. So it has mostly sensory function. It supplies both sides of the face. However, you have to pay attention to the anatomy here. The angle of the jaw here is not supplied by the trigeminal nerve. It's supplied by C2. Okay? So you have 3 divisions of the trigeminal nerve. However, the jaw angle is not supplied by the trigeminal nerve. This is for localization. Okay? The second thing is the coronary reflex is supplied by the trigeminal nerve. Of course, you don't have to examine this on every patient. Usually we do that mostly on comatose patients to examine cranial nerve. Unless you need to do it sometimes, but usually we don't do that routinely. And then the motor functions, you have the temporalis and the masseter here. When the patient bites on their jaw, you feel that, and you feel the temporalis muscles up here. That's the motor exam of the masseter. That's the 5th cranial nerve. Next is the facial nerve, 7th cranial nerve, which supplies motor to the face, and sensory, which is the taste of the tongue, okay? So the upper motor neuron lesion usually causes weakness of the lower face because of a complicated innervation on both sides, bilateral cortical. It's not that simple, but it's a very complicated system. But it's both upper face, they get supply from both sides. That's why you see in the central lesion, you see only lower face, okay? In the peripheral lesion, you see upper and lower face involved, okay? Now, to examine the patient, 7th cranial nerve, we usually examine motor. So you ask the patient to smile and see the symmetry. You ask the patient sometimes to puff out their cheeks like this, and you see if it's symmetry. You ask the patient to raise up their eyebrows, see if they both elevate the same. And one very important thing to watch on patients when they have facial weakness is the eye blinking. Sometimes it's a peripheral lesion, but the wrinkles of the forehead are symmetric. The only thing that can indicate an upper face weakness is the decreased eye blink. So you see the patient are blinking one eye, but not the other. So that's very important to watch. That's what, as we talked about, observation. So this is how we examine the face. So I'm gonna show you a case here. Don't look at the description, just look at the video for now. Let me just run the video here. Okay. And tell me, what do you think this is? What do you think the lesion is, the facial weakness? Is it upper motor neuron, lower motor neuron? Then we'll look at the history, but just from looking at the patient here. The eyes were, yeah. You see the blinking? You see she blinks the right eye, but not the left. You see that? The eye opening is more on the left than the right. Don't look at the eye movements because she has other old stuff. You see the facial droop. So is this, just from looking at it this way, is this a central lesion or a peripheral lesion?
Peripheral lesion.
Okay, now let's look at the history. So you're correct because it involves upper and lower, correct? So let's look at the history. This is a woman, 61-year-old, presented with sudden onset of dizziness, diplopia, double vision, left facial droop and unsteady gait. But she has this left facial droop, it's upper and lower. So is this, what do you think about this case? Is this a central or peripheral?
I think central, 6 and 7 facial and abducens.
Okay, so okay, so but you said 6 on which side?
Left side.
Why?
But nucleus 6th nerve and 7th near others.
I know, but like the abnormality that you see on her eyes, what's the abnormality? Because she can move her eye outward on the left side, so that's not a 6, right?
Right.
So the eye movements, as I told you, don't look at them because she has abnormal eye movements from before. So those are not new, okay?
Okay.
What I'm trying to tell you about is look at the rest of the history. So you are right. So this is central. I'll tell you why it's central. It's not peripheral, though it looks peripheral, right? It's upper and lower.
Yeah.
But in this case, no, it's not. First, the history. As we spoke about history, what did she come in with? Not only with facial weakness, she has other symptoms, right? She has diplopia,
Right.
she has unsteady gait, so she has brainstem symptoms, right?
Yeah.
So can you get like an upper and lower face in the brainstem from a central lesion? Can you get that? What should you get? Where do you get it?
In acute stroke.
But where? Where? No, an acute stroke, usually if it's central, it's lower face only. It's not upper and lower face, right? As we spoke. So
Midbrain must be.
it's midbrain, but midbrain, it depends where in the midbrain. It can be the midbrain, right? When you have facial weakness, it can be midbrain or it can be above the midbrain, from the cortex all the way down to the midbrain. But to have upper and lower, usually in stroke, if it's central, you get only lower, correct?
Right.
So there's only one place, right? Is if you hit the nucleus. Or, so if you hit the 7th cranial nerve nucleus, I'll show you where it is now. Or you hit that very small portion that goes from the nucleus out to the outside of the pons, jisr. It goes outside. You have very small area and it's in the lower pons. And if we look here, this is her MRI, okay? If you look at I'm gonna go out of. So if you look here, you see this level? This is upper pons, okay? There's no stroke there, okay? If you have a stroke there and facial weakness is gonna be upper motor neuron. And then we go one more level down here. You see that? Are you seeing my arrow? Are you seeing my arrow on the screen where I'm pointing at?
I can't see one.
No, you see my arrow that I'm moving, the mouse arrow?
Yeah.
So here it's in the middle of the pons, and you see there's no stroke. But if you come to this area here, it's in the lower pons. That's where the 7th cranial nerve nucleus is. And look where is her stroke. I'm gonna enlarge the picture here. Look at the stroke here. It's exactly where the 7th cranial nerve nucleus is, which is here. Okay, she has another one here. So this is a central 7th cranial nerve palsy that looks peripheral, but history tells us that this is different because she has other symptoms with it. It's not going to come by itself. Now we go back to what you said. Actually, the 7th cranial nerve and the 6th cranial nerve wraps around it. I'll show you a picture, anatomy picture. So 6 and 7, when it's central, they a lot of times come together, come 7th and 6th together. And so this is her MRI, but let me show you the. Okay, so if you look here, the purple, if you look at the purple nucleus there, that's the 6th cranial nerve nucleus. The red one is the 7th cranial nerve nucleus. And look how the 7th cranial nerve wraps around the 6th cranial nerve nucleus. So when you hit that area, it's very easy to hit both nerves, okay? So this is an example that history will help you because it's not only peripheral Bell's palsy, just Bell's palsy, she has other symptoms. That's where history helps a lot. Okay, let's move on. Vestibular cochlear nerve, which is the 8th cranial nerve. So the cochlear is for hearing. And hearing, we don't usually examine it. You can examine it by rubbing your fingers around the patient's ear and see if you can hear. It's a crude exam, but you can tell if the patient is hearing you or not. It's not going to be, a very good, but you can tell sometimes. And you can rub your fingers to see if the patient can hear, but it's a crude exam. The more important one is the vestibular division, which involves in eye movements and balance, right? And that's also very important here because sometimes patients come in with vertigo, nausea, vomiting, unsteady gait, and you're in the ER. You want to decide, is this a peripheral or a central, especially when it's persistent. When the patient comes in, oh, he's complaining of spinning sensation and vertigo, but it lasts like less than a minute, and then it goes away, and it's induced by head movement, but it's not persistent. This is benign positional vertigo. You do Dix-Hole-Pike maneuver, which we're not going to talk about here, but it's a maneuver to see which side they have the nystagmus and the symptoms on, and you can fix it. So that's intermittent vertigo. However, when the patient comes with persistent vertigo, that's different. That could be a stroke, or that could be, for example, acute vestibular neuritis. So there's a couple of tests here which can help us, especially if the patient has persistent, they have to have persistent vertigo, spinning sensation. They have to have nystagmus, no matter what kind. And then we do a couple of, and they have usually unsteady gait. If they have these, this exam can help you differentiate between peripheral and central vertigo. It's called HINTS, head impulse test, nystagmus, and test of skew. So let's see example. For example, this patient has a positive head impulse test. So you move the head fast. Usually you have the patient concentrate on one point, look at my nose, and I move their head fast. The eyes should be fixated, should not move. In patients who have an abnormal peripheral problem, especially in the inner ear, they have what we call correction saccade, and I'll show you here what I'm talking about. So when you move the eyes, it has a lag. So it moves after you move the head. That's abnormal. And this is just an example. That's right. So this is in slow motion. So you see how the eyes corrects and move afterwards. You see that? That little eye movements, that's called correction saccade. So it's a correction after. In normal people, that should not happen. Eyes should not move when you move the head. Okay, so that's called head impulse test. In this patients, you have unidirectional nystagmus. Towards the left. So you see when they look to the left, it's worse, but it's always the fast beat nystagmus. The fast beat, it's always to the left. Even when they look to the right, it's always to the left, but it's not as bad as what they look to the left. So the fast movement goes away from the abnormal eye. So the direction of the fast movement is away from the abnormal abnormal ear. Okay, so this is a unidirectional nystagmus, one-sided, one fast phase. Look at this patient here.
This woman has small abnormal beats of nystagmus,
so
which when she is looking to the
now
right,
the fast beat is to the right when she's looking to the right.
When she looks to the left,
now look at, now it's the fast beat to the left. So it's bi-directional. She has different nystagmus, one side and the other. This is usually a central problem. And usually it could be vestibular nucleus, it could be cerebellum, but this is a central when you have a bi-directional nystagmus. You don't always have to have that, but in patients with a central, usually the nystagmus will be as strong in all directions. Now, this is a test of what we call skew. Skew is the eye moves up and down, you know, bob up and down. But so how do you figure that out? Sometimes you can see that the eyes are one up and one down. Sometimes you cannot. You do what we call a cover-uncover test. So you cover one eye, and then you cross cover to the other eye, and you see how the eye, the right eye is moving up, the left eye is moving down, right eye moving up, left eye moving down. This is a central lesion problem. It's not peripheral. When you see that, you know that this is a central problem. So if you have a patient with if we go back with the head impulse test, if this is positive, most likely this is a peripheral lesion. If it's positive, most of the time. If they have persistent vertigo and this is positive, it's peripheral. It's the ear. It's not a stroke most of the time. Except for very small amount of patients, but most of the time you can be more confident that this is a peripheral problem. We talked about the nystagmus and the direction or bidirection. This is the unidirectional is usually peripheral. The bidirectional is usually central. And then you have the skew test, which with the cover and cross cover of the eye, and you see if the eyes goes up and down. This is called skew and hiraf yani. That's a central lesion. Usually this is a central lesion. Okay, now cranial nerve 9 and 10, if you want to examine them, sometimes we do, sometimes you ask the patient to open their mouth, you look at the uvula and the palate. When they say ah, do they elevate symmetrically on both sides the same? You can do gag reflex, put the tongue depressor deep in the side of the throat and see if they have a gag reflex. Do we do it all the time? Most of the time we don't. But if you want to expand and make sure that this is abnormal, this is how to do it. Cranial nerve 11, which is the accessory nerve, supplies the sternocleidomastoid muscle and the trapezius muscle. So sternocleidomastoid move the neck, the head to the other side. So when I move to the left here, it's my right sternocleidomastoid that is working. And when I move my head to this side, it's this side that is moving it. And you have the trapezius muscle, which is a thin, big muscle here in your shoulder area and goes to the neck here, and it moves the shoulder up. So shoulder shrug, you examine shoulder shrug, and you examine head turning. This is the 11th cranial nerve. And the 12th cranial nerve, which is the hypoglossal nerve, it involves with tongue movement. So you ask the patient to stick out their tongue and move it from side to side. See if the movement is normal or abnormal. Okay, now we're finished with cranial nerves here. We move on to the motor exam. So motor exam, first observation, you see, does the patient have any atrophy of the muscles? Is there a shrinkage of the muscles? That's very important. Do they have any spontaneous movements? And that's part of their motor exam. Do they have abnormal movements? Do they have chorea? Do they have myoclonus? Do they have asterixis, which is a negative myoclonus? When they're holding something, it drops instead of the positive myoclonus this way, which goes against gravity. It's actually, this one is like, boom. And sometimes patients can have it in their legs and they can fall because of that. A lot of times it's because of medications, usually gabapentin. When patients have acute renal failure, we see that a lot. So you see the patient, you see their muscles, you see their bulk, and then you check muscle tone. To check muscle tone, you check for rigidity. So you move them, the arm or the leg in different directions to see if the patient has rigidity. To check for spasticity, for the upper arm, you have to, spasticity is velocity, induced. So you have to move the arm fast and you get a catch and then a release, a catch and then a release. That's a sign of spasticity. You can do it on the leg too by holding the thigh quickly up, and usually the leg slides on the bed. If there is spasticity, the foot will hold up above the bed when you pull the leg up. And then you examine muscle strength. So in the upper extremities and the lower extremities, you examine muscle strength. So hand grip, or also interosseous muscles. You can ask the patient to spread out their hands and try to check the muscle tone, wrist extension, wrist flexion, biceps. You ask the patient to do this, and you check their biceps, and to push out, check their triceps. Deltoid, I usually have the patient do. This is middle deltoid. There's anterior deltoid that you can do. You cannot do posterior deltoid, but this is good enough to check their deltoid muscle weakness. If you want to expand more, you can do pronator, you can do supinator, you can do external, rotation of the arm or internal rotation. So you can expand more. It depends on what you're looking for in the muscle strength exam. So you have also in stroke patients, we ask them to do something to check for subtle muscle weakness, which we call the pronator drift sign. So we ask the patient to hold their arms up like this and close their eyes. In pronator drift, you see it's a pronator, right? The pronator muscle pronates the hand. So pronator muscle and pronator sign, the patient will pronate their hand, so it will turn in this way. So that's a sign of mild muscle weakness. Also, we use finger tapping. Sometimes patients have loss of dexterity from the weakness. So when they tap the fingers, so we ask them, tap your fingers. And usually they're like very slow on the weak side. Sometimes even the grip is good, the strength is good, but they have mild weakness and they have decreased dexterity. So you see the left one is good, but the right one is like real slow. And that's sometimes is a problem for some stroke patients. Usually you see that more when it's by itself, a lot of time in the cortical lesions, but not necessarily all the time. So finger tapping, and then of course you do the motor exam. Sometimes it depends on the patient. They might have previous weakness. So you have to ask the patient, you examine the patient's shoulder and they are weak. So you have to ask them, sometimes they have a history of rotator cuff, they cannot raise their arm up, or they have a history of arthritis, they cannot raise their arm up. So you have to clarify if this is for them, this is a new thing or this is an old problem. So we talked about muscle bulk, muscle tone, abnormal movements, spontaneous movements. You see sometimes patients, they have fasciculations. If you come into a patient and you see a lot of atrophy, always tap their muscles. See, do they have fasciculations? They could have underlying ALS, for example. So you check that. Of course, you have other signs, but to elicit the fasciculation sometimes on the thigh or on the upper arm, you just tap on the muscle and see if you can elicit fasciculations. This is just tables on the muscle strength grading down here from 0 to 5. Some people do 3+, 4+, 5-. If you don't want to make it too complicated, just use this grading system. It's good enough. When the 0, no movement. 1 is a flicker of movement, just very little movement. 2, they move it side by side, but not against gravity. 3, against gravity, but they cannot resist at all. 4, it's against gravity, but they can resist some. 5 is full strength. And these are usually the muscles that we examine. That's the most common muscles that we examine. You can look at this later at this table. Okay, sensory exam. So we have primary modalities, which is touch, pain, temperature. Those are transmitted by unmyelinated small fibers. And then you have the myelinated large fibers, which usually transmits vibration and proprioception. So how do we check for? So most of the time, the light touch is good enough. The pinprick, I don't like to use the safety pin. Sometimes I feel it's too, sometimes I use either a toothpick or like I have, for example, those Q-tips. I break them and make a pointy edge and try to examine the pinprick exam. The problem with the pinprick is sometimes you don't apply the same pressure on both sides. So you have to try your best, but sometimes the patient it can be difficult for some, especially elderly and confused patients. You cannot apply always the same pressure. Or if you have on the foot, you have to make sure you don't apply it on like areas which has like thick skin or calluses. So you don't do that on this areas because they're not going to feel it as well. So you have to do the pinprick on a clear skin. Temperature is good. Another modality, usually I use my tuning fork. It's usually cold. So I ask the patient if they feel hot or cold. For vibration, you have the vibration fork. Everybody know about this, the vibration. If you need to examine it now, do we do that on every patient? No. So tuning fork, you hit it, you put it on a bony prominence, and you ask the patient. And proprioception is you move a joint up or down, and you have the patient close their eyes, and you ask them which way I moved it, up or down. So you might move it up and up, so they have to know which direction you moved it. That's proprioception without any visual cue. All right, those are the primary modalities. Now, if you want to go more deeper, you have cortical sensory modalities, which are more complicated. So those primary modalities that we talked about can be combined into more complex sensory modalities that are sensed by the cortex. For example, stereognosis is if you put, for example, a key or a coin in the patient hand and ask them to close their eyes and try to feel what is this. So for us, if I hold something in my hand, I know that this is a pen, right? So this is called stereognosis. You can examine it in patients you think they have parietal lesion. Graphesthesia, you can draw a number on the patient's hand and ask them, like, what number I draw on your hand. For example, you do number 4, number 6, I should be able to tell, and that's called graphesthesia. So this is cortical sensory modalities. Now, the more important than these that we use in stroke patients specifically is called double stimulation or double simultaneous stimulation. So when you think the patient has neglect to, especially usually in right parietal lesion, they have neglect to the left side. So the way to examine the patient is to touch both sides at the same time and ask them, which side am I touching you on? If they have a neglect, they will tell you only the right side. But if you do only the left side, if you touch only the left side, they will tell you it's the left side. But when you do simultaneous stimulation, they will feel the normal side only. They will neglect the other side. It's called extinction. So they extinct to that abnormal side. Now, the same thing can happen in visual fields. So when you ask them, like, which side do you see my fingers are wiggling on, they will tell you only this side. But when you stimulate just one side, the abnormal side, they will tell you that so this is not a true visual field cut. It's not a true hemianopsia, it's a neglect. But when you do one side and they cannot see on that side, that's a true hemianopsis hemianopsia. But when you do both sides, they see only the right, but you do only this side and they can see only the left, that's a neglect, okay? That's called double simultaneous stimulation. That's very important in stroke patients. If you feel like the patient has some gaze preference or they have some unexplained sensory modality, always do that. Double stimulation, it's easy. It's the same, but you ask them, close your eyes, tell me which side I'm touching you on, and they will tell you right, only right, if they have a neglect to the left side. That's a parietal lobe, usually a large stroke. Next, coordination. Coordination is usually a function of the cerebellum, right? But of course, involved in that also is the vestibular system too. But coordination, first you have like a truncal stability, gait, also coordination of the extremities, limb coordination. So to test that, we do finger to nose testing. So you ask the patient to touch their nose and touch your finger, and I usually move my finger around. So I don't keep it at the same, so I do. So usually they have to be accurate. In patients with a cerebellar sign, you see when they come close to the object, they go and they miss it. They don't go to the tip, they miss it, or they go up or down. So that's a dysmetria, we call it dysmetria, right? So they have a little bit of tremor, but then they miss it. In patient with essential tremor, for example, they have a little bit of tremor, but they're accurate eventually. They can get it on the object. But in patients with cerebellar problem, they usually miss it. They don't get it. When they go to their nose, they don't touch the nose. They go out to the face or to the mouth. A heel to shin test, same thing. You ask the patient to put their heel on the shin and go up and down on the shin of their lower leg. And in patients with cerebellar problem, it will go sideways. It won't go smooth up and down. It will go sideways. And then the rapid alternating movements, there are two. You can do the finger tapping. That might be a sign. In patients with cerebellar, it's usually irregular. Or you can do what we call, look for dysdiadokinesia. So ask the patient to flip up and down the one side and the other, and to see how fast and how accurate they can do it. So this is limb coordination. And of course, when somebody, you watch them in bed, if they sit in bed, if they have truncal ataxia, they cannot sit still in bed. They are like falling backwards or falling to the side or falling to this side. So that's for truncal ataxia. Usually, this is a function of the vermis, which is the middle side of the cerebellum, the midline of the cerebellum. Next, reflexes. You know reflexes. These are biceps, triceps, brachioradialis, knee jerk, ankle jerk. Don't use the small triangular head reflex hammer. Those are not very good, not heavy enough. You need a heavy reflex hammer. And you need to make sure you put your finger on the tendon. Sometimes some doctors, they hit the muscle and you can get what looks like a reflex, but that's not, that's myotactic reflex, not a tendon reflex. You need to put your hand or your finger on the tendon itself. And of course, in the leg, you need to hit the tendon, and they're large. Sometimes the triceps tendon, it's hard to get in some patients. It depends on the size and the fat. So sometimes it's a little bit difficult. Brachioradialis, usually you can most of the time get it when you hit on the tendon of the brachioradialis. So you see symmetry, you see, is there absent reflexes, and that make you think it depends on the one side or the other side, or they have like hypoactive reflexes all over, or hyperactive. That might tells you that there is a spinal cord lesion if they have hyperactive reflexes in both upper and lower extremities, or it's a upper motor neuron sign, not necessarily spinal cord. It could be motor neuron disease. So don't use, as I told you, the small triangular hammer. This is what I use. You don't have to use exactly, but this it has to have like a heavy head, and you have to try to hit on the tendon, of course, with your finger on the tendon, but you have to let it drop, give it some, some to get some strength to get that reflex elicited. And sometimes the position, if the patient is laying in bed and you check in knee reflex, if you don't bend the leg, you're not going to get a knee reflex, a good knee reflex. So sometimes, if you can, sometimes we can't, sit the patient on the side of the bed. That will be the perfect position for the patient to examine reflexes. Next, there's a reflex that we can check, which is clonus. Clonus can sometimes checked by the reflex hammer in patients who have like hyperreflexia.
Reflex. I never examine reflex in stroke patients.
Well, I know, but you have to mention everything, as I told you, and then you can tailor your exam based on the patient. And I understand a lot of things.
Excellent. Honestly, I really learn a lot with the videos, with the explanations, but mashallah is excellent. How many minutes do you think you need, Dr. Ziad?
Almost done. Few minutes. I promise. So clonus, sometimes you can check the clonus at the ankle. So you hold the foot like this and you dorsiflect the foot. And if you have sustained clonus, that's a sign of or sometimes with the reflex hammer, if you have severe hyperreflexia 4+, when you hit on the tendon, the limb will jerk. That's a clonus too. But you can check it on the ankle. You hold the ankle and dorsiflect the ankle, and sometimes you get non-sustained, like a few jerks, or you get sustained clonus in patients. Usually you're not gonna see that. Okay, so in patient with stroke, coming to patient stroke, usually the limbs that affected by the stroke in the acute phase, the reflexes are down. The reflexes are hypoactive. When does the hyperactivity comes? It comes later in the recovery phase. That's because of the corticospinal tract. But in the recovery phase, not in the acute phase. In the acute phase, in patients with strokes, most of the time reflexes are down. Papinski, you know Papinski, if this is the foot, you go outside, you don't go inside the foot. So if this is the big toe here, you go from outside. This is how we check the Papinski, and you look for the big toe, not the other toes. You look for the big toe and make sure it's persistently going up if it's positive. If it's not persistently going up and you're not sure, don't call it. Okay, now gait. The last thing is gait. Gait is very, very, very important. If you can do one thing on a stroke patient, if you can, sometimes we cannot do gait because you can examine many things with gait. You're asking the patient to get up. So you imagine the patient laying down, he has to sit and stand and understand what you are telling him, and then get up from the bed and stand up. So a lot of sensory, vestibular, cerebellar, motor. You see this when the patient is getting up from laying down to standing up. And then you watch the patient, you watch their base. What's their base? Is it normal base? Is it wide based? Are they taking small steps? Are they limping? Are they dragging their leg? So you watch their legs, but not only their legs, you watch their arms too. Are their arms swinging? In normal people, we swing our arms. In patients with weakness in one arm, you have decreased swinging. In patient with stroke, you have decreased swing. In patient with Parkinson's disease, you have decreased swing. And then you see how they turn when you ask them to turn around, how they are turning. So gait can give you a lot of, idea about the patient, function in general. So those are different kind of gaits, and where the lesion is with these gaits, you can look at this later. And I'm gonna show a couple of videos, and we'll end up with one. But I'm gonna go quick on these videos, so I might skip some quickly. But for example, this is a patient with a history of stroke, and he has hemiplegic gait.
This patient has a left hemiparesis. He walks with a stiff left leg. The leg circumducts to avoid hitting the ground in swing, and the landing of the foot is flat.
Okay. This patient
has a degenerative ataxia and walks with poor balance, a wide base, and irregular steps.
See, wide base down here. Other patient was
there is also an occasional lurch.
Okay. This is a physician imitating a Parkinson's gait.
Lean forward, and then we'll have difficulty as far as initiating gait. When the gait is initiated, there are small steps. Oftentimes there's a tremor associated with this. And as the gait progresses, there may be a picking up of speed, or what's called administrative gait. And then in turning, instead of having the normal turning, the patient will turn en bloc. Which means they'll turn many others, but I didn't almost a statue moving around.
So this one is psychogenic gait. We get that sometimes with stroke patients. So this patient is, like, you see how much effort she put in trying to balance herself, but this is all psychogenic. Even sometimes you'll see that she can fall, but she's not gonna harm herself. But this is needs a lot of efforts to do all these movements that she's doing to get her balance, There's another one, which is a more, so this patient has tremor on standing up, which is all psychogenic also. But when he walks also, you see he takes a step backwards, which needs a lot of muscle and a lot of balance to do that actually. So this is all psychogenic gait, okay? Now I end up with one video. I know my lecture has been long and boring, but this is the last one. Okay, that concludes my lecture here. If anybody have any questions, please let me know. Please ask questions.
Dr. Ziad, Jazakallah khair. It's a wonderful, wonderful talk by all means with the slides and all those things. Thank you very, very much, Dr. Ahmad. I think Dr. Abdul Rashid, Dr. Aisha, I don't know if they are with us. They are our ambassador to Mogadishu and to Somalia and to Pakistan. Many thanks for coming. And really the idea is we're going to give these lectures every 2 weeks by speakers from all the world in the regions and in North America and in Europe. And if you can, let your team, any physicians, internists, neurologists would like to come on and attend this, just please spread the link. You will be the ambassador for us, Dr. Abdul Rashid, and I think Dr. Aisha was there, but I think she's already left. The one who didn't have chance to attend, I think there's gonna be video of the broadcast of the lecture.
So any questions? Anybody has any questions? I cannot read the chat. So moderator, if anybody has any question, please let me know.
الله يجزيك الخير دكتور زياد. بالعربي ولا بالانجليزي الاسئله؟
اللي بدك اياه. اذا حدا عنده بالعربي ما في مشكله، بجاوبه بالعربي.
هلا في بس سؤال دكتور زياد. هلا في من فتره يعني المقوي بعد الستروك انه بعد 10 ايام اذا تغيرت المقوي انه علامه ايجابيه ممكن المريض يتحسن، اما اذا ظلت المقويه ناقصه هاي علامه انذار سيئه ممكن المريض ما يتحسن. شو الصحة مظبوطة هي؟
ما هو حسب شو المقوي زادت، بحسب إذا عندك الكوريكوسبانال tract was affected and you have increased tone ممكن المقوي تزيد كتير وما ضروري ما معناته المريض رح يتحسن، لا ما له علاقة المقوي بتحسن المريض فعليا. إذا زادت لا ممكن يصير عنده مشاكل أكثر وكان عنده increased tone مثل المريض اللي شفناه. يعني هلا احيانا increased tone ممكن يساعد اني in some movements and hold the muscle like يقوي العضله مثلا ممكن تتحرك احسن، بس مو indicator اني المريض راح يتحسن. هلا increased tone as I told مثل ما قلت لك يعني ممكن احيانا يساعد شوي بحركه المريض، بس احيانا بيكون كمان عامل يعني مشكله بيعمل للمريض مشكله بالعنايه كمان، شلون راح يلبس شلون راح كذا. فكثير احيانا بنعالج المرضى الستروك ببوتوكس مثلا to release some of that increased tone زياده المقوي. بالنسبه للمرضى اللي عندهم ما في مقويه او مقوي بيكون ضعيف المريض كثير. هلا ما دائما بيكون يعني هي المشكله معقده اكثر، هي تعتمد على في العصبونات المثبطه والعصبونات المقويه، كل مريض شكل يعني. بس صعب البروجنوسيس بصراحه كثير صعب بمرضى ستروك، كل واحد شكل حسب اللوكاليزيشن محل الستروك وحسب النيورونز اللي انفولد بالستروك. ما بعرف اذا الدكتور ماهر في عنده جواب احسن مني.
لا ما شاء الله كفيت ووفيت ما شاء الله. يعني في studies looked at the cross leg sign. إذا مريض عنده ال cross leg sign it's a good sign for improvement. cross leg sign يعني عرفت كيف؟ but exactly what
يعني بتطالبوا رجلتين ان هاي ممكن ان في حركه اكثر فممكن يتحسن المريض خاصه انه يقدر يمشي يعني.
yeah. wonderful.
اي سؤال ثاني؟
reinforce that Dr. Abdul Rashid
ما في أسئلة ما في أسئلة.
يعني the Zoom link to all the physicians in Somalia and إن شاء الله.
ان شاء الله. لا تواخذونا اذا طولنا عليكم شوي، بس يعني الموضوع لسه اكبر من هيك بكثير يعني بنحكي فيه كثير.
I will try next lecture just احكي على NI stroke scale. Just try to what you pointed is to take what saying that this is very important. This is very important subject. بنضيف آخر 10 دقائق ربع ساعة كمان يعني بحيث إنه أي واحد عنده استفسار باللغة العربية محتمل نشرح باللغة العربية إن شاء الله.
ان شاء الله.